Good morning, everyone. My name is Margie Giuliano, and I'm the Medication Safety Task Lead for the New England QIN-QIO, and I'd like to welcome everybody to today's webinar. Today we're going to be exploring highlights from home, innovative approaches to enhance care transition and medication, specifically highlighting some of the efforts that the QIO is proud to support across New England. Before we get started, I'm going to quickly review a few housekeeping items. The call will be recorded, and the recording will be available within a few business days. This will be on our website. The phone lines will be on mute while the speakers are talking, but we will unmute the lines after the presentation for questions, and I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we would still like you to actively participate during the session by using our chat function. My colleague, Lynn Chase, will be monitoring the chat window and responding to your comments in real time. So don't be shy. We'd love to learn more about your efforts and how we might best support you going forward. We'd also love to hear your thoughts about what the speakers are saying. It's important to note that today's speakers have no relevant conflicts of interest to disclose. So let's test out our chat feature and find out who's on the call. Please type in your name, your role, your organization, and your state. While you're doing that, I want to review our learning objectives for today. So upon completion of this session, participants will be able to describe how these two programs utilize available data, collaborative input to inform their efforts, how to leverage the identified best practice tools to support home health care transitions, and explain how long-term services and support providers such as SASH can help medication safety during transitions of care. Again, using our chat feature, we're really interested in understanding what you're hoping to gain from today's session, so please let us know. At this time, I'd like to introduce our first two speakers today. Eileen McAdoo has been in home care since 1999, including private duty nursing, case management, and for the last 13 years has overseen quality assurance at All About You Collaborative Healthcare Services. Melissa Gordon is a Senior Director at Qualidyne, the New England QIN-QIO, and has over 25 years of experience in the healthcare industry. At Qualidyne, she oversees the strategic operations of the Home Health Consulting Division and works directly with home health agencies to advise and recommend quality improvement strategies. She's also the Regional Home Health Lead for the New England QIN-QIO. Melissa has been in both clinical and operational roles for nonprofit Medicare certified home health care agencies, and prior to Qualidyne, served as the Director of Continuous Care Management and Manager of Transitions of Care at the VNA of South Central Connecticut. Her professional area of specialization is in negotiation and developing and sustaining customer relationships in support of business goals. She's a registered nurse and holds an MBA from the University of New Haven. I will now turn this over to Melissa.
Thank you, Margie, and good morning, everyone. I'm so glad that you've joined the webinar. Again, the title of the webinar is Innovative Approaches to Enhance Care Transitions and Medication. And before we present the innovative approaches of what we're doing in home health, I'd like to take a moment to talk about care transitions, which is a very important process in the setting of every continuum. So what is care transition? Well, as defined by the Centers of Medicare and Medicaid, care transitions, or transitions of care, is the movement of a patient from one setting of care to another, from one setting such as hospital, ambulatory practice, long-term care, and home health. And other experts define it as the patient flow. And over the last few years, it has become the buzzword in healthcare, and most recently in home care. And some examples of care transition models that you may be familiar with are the Pullman model, the Transitional Care Model, or TCM, the Better Outcomes for Older Adults Through Safe Transitions, or the BOOST model, and Project RED, which is the Re-Engineered Discharge model. And one of our favorites here at the QIN is the Interventions to Reduce Acute Care Transfers, or the INTERACT model. And we'll discuss INTERACT in a moment. So you ask, what are the benefits of focusing on care transitions in your organization? Today, we are presenting innovative approaches specifically to home health. But you will see these approaches can be effective across the continuum. The benefits of a solid, efficient care transition are many, which include increased communication between settings, increased patient satisfaction, improved quality of care, decrease in rehospitalization, improved medication compliance, and those are only to name a few. What can you do to make a transition successful? Well, it's all about communication. And after you hear the tools presented, you'll notice that one common theme: enhanced or improved communications and the strategies associated with communication.
With the flu? Oh, yeah.
And as we think about transition, we focus on communication and asking the right questions. The key to a smooth transition from any setting is to ask, does the patient know what to do when they get home, for instance? Specific areas of concern are usually medication review and reconciliation, and today we will have a presentation on an innovative solution that addresses this issue when transitioning. Self-monitoring and emergency care planning. When the patient is being discharged from specifically to home, can he or she self-monitor and or is able to know what to do in case of emergency? Patient-centered goals of care. Is the patient contributing and or know what the goals of care are when they're transitioning? For example, do they even know what home care is? Physician update and follow-up. When you're doing the transition, do you keep the provider or the physician in the know? And the usual follow-up appointments. Have the appointments been made? Were they made during the hospitalization, but now the patient can't keep them when they get home because they have no transportation? So now that we've reviewed what a care transition is and that effective communication is key to a successful transition, I'd like to share what the Connecticut QIN and their many stakeholders created to reduce hospital readmissions. So in 2016, the Connecticut QIN put a call out to stakeholders to participate in a collaborative. A collaborative we named appropriately the Home Health Readmission Collaborative. We had many interests from our stakeholders, all experts in their field across the continuum in Connecticut, many who are on the call today, and a shout out of thanks again to them. From this initial meeting, we got to work. We established the goal: reduce preventable readmissions, to provide an opportunity for home health, hospice, and palliative care providers and their stakeholders to identify areas of improvement. We had a few meetings, broke out into groups, and decided after much work in testing and piloting the 5 tools that you see in front of you: the Stop and Watch tool, the High Risk Assessment tool, the Call Me First tool, the SBAR tool, and the Physician Education tool. I'm going to pass it over to Eileen in a moment, and she's going to detail the first 3 tools for you. The SBAR tool that was decided to use and roll out is currently used by many agencies as your nursing communication tool, and many of us are familiar with this tool because we all learned it in nursing school. This tool is supported by the Institute for Health Improvement, and we know it as the situation, the background, the assessment, and the recommendation. And it is mostly used to inform and prepare when communicating with the physician. I'll talk about the fifth tool, the physician education tool, in a minute, and now I'm going to pass it over to Eileen.
Thank you, Melissa, and good morning, all. So All About You Home Care was one of the many providers across the continuum that participated in Claudine's task force to reduce home health readmissions. As mentioned, Claudine is part of the New England QIN-QIO. So the first tool we're looking at here is the Interact Stop and Watch Early Warning Tool. This was piloted by the Social Determinants Task Force, which was led by Dale Hayshe from Yale New Haven Hospital. The tool offers an algorithm that prompts care team members on reportable patient change in condition. The tool encourages ownership by the entire care team to be part of monitoring for change in patient condition and reporting the change promptly. Given the task force work with this tool, we as an agency are implementing the tool as part of our home health aid orientation process to educate aides on changing condition and what to report. This is a tool that can certainly be utilized across the continuum. Our agency participated in the Organizational Process Task Force, which was led by Florence Johnson from Claudine and Angela Leonzi from Stratford VNA. Both wonderful leaders I can speak highly of. One of the tools the group considered was the self-assessment of hospitalization risk that you see pictured here. This tool can be found in the Home Health Quality Improvement Fundamentals of Reducing Hospitalization Best Practice Intervention package. The task force, when looking at the tool, did make some minor changes to the tool, including the addition of the line in the past year for home health, and to the indicator, live alone, we added the line, do not have the help that I need. We piloted the tool in our Torrington office, which is a mixed population of medical and behavioral health patients. As a part of the process, I met with the staff biweekly post-implementation of the tool to monitor its use and also reported basic metrics to Claudine on a monthly basis. One of the barriers that we did experience with the tool was that not all patients were able to complete the tool, such as patients with dementia. However, anecdotally, staff did report that the tool assisted in identifying the patient's understanding of their hospitalization risk and the patient's health goals. It opened the door to dialogue of what the agency could provide to assist the patient in reaching those identified health goals. It also gave direction to our staff as to where the patient and or caregiver educational needs were in relation to hospitalization risk. In light of the new Medicare conditions of participation for home health requiring agencies to identify and address patient hospitalization risk, subsequent discussions by the task force to reduce home health readmissions supported the use of the tool as a way for agencies to meet this requirement. We have implemented this tool agency-wide, and we continue to reinforce its use in light of the new conditions of participation. This tool is also a tool that introduces the Call Me First poster. The Call Me First poster is also a tool that can be found in the Home Health Quality Improvement Fundamentals of Reducing Hospitalizations Best Practice Intervention package. This was a tool the committee also made some minor changes to, including the line, have a question about your medication, and made, in case of an emergency, call 911 more visible and bold with the red. The tool promotes patients calling the main line for the agency to assure all calls are received and responded to in a timely manner. We use the tool in conjunction with the My Emergency Plan, which is a tool that identifies specific symptoms and what would warrant a call to the agency versus 911. The tool was piloted in our Torrington office as well and followed the same methodology of meeting the staff biweekly to monitor its use in the monthly reporting of basic metrics to Claudine. Anecdotally, the staff did report that patients seem to be calling more frequently and appropriately, and we did have a few patients actually call referencing the Call Me First poster. At this point, we have implemented this tool agency-wide and continue to reinforce its use. And it's definitely a tool that can be used across the continuum. And at this point, I'm going to send it back to you, Melissa. Thank you.
Great. Thank you so much, Eileen. And our last tool is the Physician Education Tool. This tool was also created by Yale, piloted, and its purpose is to educate physicians within the health continuum as to the capabilities of home health care. It briefly talks about what services are available and who should be considered for home health upon discharge. It also addresses what Medicare will cover and what is needed from the physician to have an appropriate home care admission. So next steps. You can find all these tools on the New England QIN-QIO website under Home Care. Our next steps is that you take these tools and you spread them as best practices across your state and region. And next you will hear about an innovative approach to med reconciliation. Thank you, and Eileen and I will be available after the webinar for questions. Now I'm going to turn it over to Margie.
Thank you, Melissa, and thank both of you, Melissa and Eileen, for such a great presentation. It's now my pleasure to introduce our next speakers, Christy Paleman and Marty Irons. Christy is a member of Cathedral Square Corporation's Innovative Support and Services at Home, or SASH, program team in Vermont. SASH supports senior living in affordable congregate housing or surrounding communities to age well in place. She presently serves as SASH Health Systems Educator for the Hypertension Management Program and as SASH Statewide Nurse Consultant, supporting nurses on the SASH model. Her experience encompasses clinical, healthcare IT, and management roles. Christy's clinical care background spans multiple patient care areas from home health to outpatient cardiology to intensive care. Marty Irons is a pharmacist and has practiced in community, military, and industry settings. He earned his Certified Diabetes Educator credential in 1990. Marty has been the recipient of numerous awards, including the Vermont Pharmacists Association's 2009 Innovative Practice of the Year Award. For 11 years, he's practiced at Beauchamp and O'Rourke Pharmacy, a community pharmacy set in central Vermont. His focus in recent years has been reconciling medications for complex patients while bringing patient care stakeholders together in new forms to improve patient care. Christy, I'll turn it over to you.
Thank you. Good morning, everybody. This is Christy Paleman, and I am here to share some information about the SASH program and a community collaborative pilot that we have just launched with Marty and his team at Beauchamp and O'Rourke Pharmacy. So support and services at home, which I'm going to refer to as SASH from here on out, is a housing-based service model that uses a population health approach to comprehensive care management by integrating health and social services with home at the nexus. The program itself was pioneered in 2009 because of some residents at Cathedral Square Housing. They asked us to figure out how they could age well at home, and so we figured it out with them, and we have been going strong ever since. We started out with one pilot at one affordable housing site in 2009, and now we have expanded to include other affordable housing groups all across the state of Vermont. SASH is committed to aiding our participants to age in place, and this is the ability to live in one's own home and community safely, independently, comfortably, regardless of age, income, or ability level. Importantly, SASH takes a population health approach. The SASH staff is comprised of a care coordinator and a wellness nurse. They're hosted by the Affordable Housing Organization, and these staff and the collective community partners will focus their efforts on a group of about 70 to 100 participants. They find out what the health challenges are that are most prevalent and work with the population to make positive change. SASH is a system of partnerships and relationships, and we have 65 partner agencies being home health, mental health, agency on aging, nonprofit housers, primary care, and hospitals all across the state. These partners sign on to what we call the SASH Collaborative Memorandums of Understanding, and this is for us to be able to work together on behalf of our participants. SASH is available through Vermont, as I shared, and this is a picture of our map that shows you with all of the little stars that the program is available at 140 affordable housing sites across the state. The SASH program, the participant is in the driver's seat. SASH is a person-centered model, meaning that the participant makes all of their own decisions. It is a voluntary program. Participants are informed and empowered to make decisions for themselves and set personal goals. SASH is their system. As either a wellness nurse or a care coordinator, and think of a care coordinator as a community health worker, we ask ourselves, what do I need to know about our participants as people to give them the best care and support possible? There are three main components of the SASH model. Those are care coordination, self-management, which includes chronic disease management, and transitions of care. Every participant has an annual wellness assessment with their wellness nurse, and that is where we learn key health information, and this is one of the times that we perform medication reconciliation in the home. And just to focus on transitional care for a moment, our wellness nurses and care coordinators will provide support on transitions into the hospital, and sometimes those are planned, and discharges to home. We see our participants when they return home, and at that time we will review their discharge paperwork. We will again perform that medication reconciliation in the home. We will identify gaps in care and help create goals as appropriate. Here's a breakdown of our participants. We have about 5,000 participants. To be exact, it was 5,033 about 2 weeks ago. We have 80% have Medicare, 68% are women, 34% men. The age range is 22 to 101. Most of our participants live at the affordable housing sites. However, we do work with participants in surrounding communities, and that is it's approximately 25% of our people. Participants span all health care needs. We have no discharge policy, so our participants stay with us as long as they want. And I showed you the map of Vermont. We're available in every county. There we go. So let's take a look at one of our participants, and I'd like you to meet Amy. Amy is 65 years old. She lives at one of our housing sites with her husband. She has a host of chronic conditions, as you can see, and one of those being hypertension. And Margie mentioned I am in charge of a hypertension management initiative. So she recently was also discharged from the hospital after suffering a heart attack, and she joined SASH after that discharge. Through her assessment, where we performed her med reconciliation, we noticed that in addition to all of the other medicines that she was taking, we saw that she was on lisinopril at the time that we started working with her on blood pressure. She has atrial fibrillation, and she's also an insulin-dependent diabetic. She came to us because she had newly diagnosed proteinuria as well, and she was receiving a referral to nephrology. She was becoming very concerned about her kidneys. On the right, we have an example of what we call the Wheel of Life. You may have seen these before, and we use these during person-centered interviewing. And what I'd like to point out to your attention are two things. One, Amy rated her attitude at a low level, and she rated her health at a low level as well. And she rated these areas low because of the number of chronic conditions, recent hospitalizations, but more importantly, she was feeling quite overwhelmed, and she was dealing with a lot of health issues. So we started working with her. She came to the blood pressure clinic, and we started working with her and educating her on home blood pressure monitoring. She was trained by the SASH nurse, and the SASH coordinator followed up with supportive phone calls, offering additional assistance, additional training. And Amy was provided one-on-one follow-up at weekly nurse-run blood pressure clinics. We improved accountability through the SASH wellness nurse faxing the flow sheets over to the nephrology clinic, and Amy also participated with some hypertension education programs that were going on at her housing site. So let's take a look at some data. Amy first came to blood pressure clinic on March 26th, and her systolic blood pressure was 154, which isn't horribly bad. But then you can see on March 29th a systolic blood pressure of 184. And you'll also notice she's only taking her blood pressure once a day. So as flow sheets were being faxed over to nephrology, it seemed like the team was starting to get into action, and Amy did too. She started to engage more. She started checking her blood pressure twice a day, which was fantastic. And you can see on April 15th, the nephrology office added amlodipine 2.5 milligrams to the lisinopril dose. And about 2.5 weeks later, her systolic blood pressure was below 140, which at that time was our goal. And you'll be happy to know that she continues to monitor her blood pressure at home. She did enroll in one of the Stanford Healthier Living with Diabetes classes, and she continues to work on her health issues with SASH as her support team. This class was offered by the New England QIN-QIO. These are free classes, and you can always refer your clients to those programs. They're fantastic and very beneficial. I was also informed that Amy is going to, just offered some information last week on her, that she's going to be trying out Tai Chi, and Tai Chi is offered at her housing sites on Friday afternoons, and this is a huge move. This is a significant positive step forward for her because she usually is not a joiner. She does not like joining in the group activities, unfortunately, so this is a big step forward. So let's switch gears a little bit. Now that you have a basic knowledge of SASH, the program, and how we've used that platform to care for a patient with hypertension, I'd like you to hear a bit about expanding our community linkages to include pharmacy. So back in August, I had a conversation with our colleagues, Margie being one of them from the New England QIN-QIO, about medication reconciliation and some education for the nursing staff and really tightening up our processes. But as we had this discussion, it turned to how does SASH incorporate the expertise of pharmacy into our SASH team. And quite frankly, the local teams will engage pharmacy sporadically when a question or a complex need arises, but not on a consistent, they're not part of a team, and they're not an official partner as well. So enter Martin Irons, a pharmacist within our community, and Martin is also a certified diabetes educator at the local pharmacy, Beauchamp and O'Rourke in Rutland, Vermont. So Marty, can you talk for a few minutes, please?
Sure. Thank you, Christy. So in the last few years, there's been a big transition for us in our community pharmacy. We've done blister packs for S&F for some time, but there actually became kind of a demand in the community from families asking for blister packs for their family members who are having trouble managing their medications. So there's been a dramatic rise in the number of blister pack meds provided for patients. That was fairly easy to do when you're working with a skilled nursing facility because you would have a reconciled list of meds. But working with patients in the community really required us to be very proactive in finding out how to reconcile the meds. And so from there, by doing a lot of asking, I now have access to our local hospital EMR. I get a fax summary every day of my patients who've been admitted to the hospital and a list back also of who's been discharged. Our patients that are blister packed are actually highlighted within the hospital. So if one of my patients is admitted, special focus is put on that patient at the time of discharge. I've also worked to identify the case managers at not only the hospital, but the skilled nursing facilities and our community health centers to help kind of complete the circle, I think the first slide had all the different caregivers with the patient in the center, and pharmacy was one of those little caregivers off to the side. But in reality, everything in terms of medication for a patient feeds through the pharmacy, but we weren't always getting the information that we needed. As a matter of fact, a patient several years ago was stopped on a critical heart medication while she was in the hospital. Nobody notified us at the pharmacy level. When she came home, she asked for renewal of all her meds, which we sent to her, which actually put her right back in the hospital again. Obviously, something needed to change. So we've created all these different ways of access, of working with other partners. So with the SASH partnership, what we're able to bring to the table is not only can I identify the meds, we can identify the correct doses, we can use all these different assets. As a pharmacist, I can tell you if SASH calls me and asks, is John reviewing his medications, we can say yes. But the advantage SASH has that I don't is that they can go in to see John and see if John is actually taking his medications or if they're just building up in the closet. We've had many cases of patients that happily receive the blister packs every 28 days but actually weren't taking the medications, weren't taking them correctly, or were just kind of picking and choosing from the medications as they went along. So, with this new SASH project, the Community Pharmacy SASH project, we've taken that transition from reactive pharmacy to proactive pharmacy to where we actually, we had a meeting just a few weeks ago, and with the SASH panel, other stakeholders, and myself, we were able to identify many gaps in care, medication care, and in some cases I was able to fix the problem within a few hours. Some things required some calls to doctors to settle, but essentially we were able to turn ourselves into a kind of rapid pharmacy diabetes care response team. And that's just working with 20 patients with diabetes or prediabetes. We've been able to also identify, are they using drugs for cholesterol? Are they taking an ACE inhibitor? Are they using aspirin? How do all their diabetes meds kind of correspond with their blood work for their blood sugar and their kidney function and their cholesterol? So it's been a dramatic change. And I told you about the patient who didn't do well with the discharge 3 years ago. Well, about an hour and 35 minutes ago, I got a notice that one of my patients was coming home from the hospital, one of my blister pack patients. The doctor was sending her home on a diuretic, but the patient was already getting this diuretic in her blister pack. It was a different dose. In the old days, in 2015, we would have filled a new prescription at the higher dose and sent it to the patient, no questions asked. But in 2018, when we looked to see what the patient has on hand, I contacted the prescriber at the hospital. We modified the dose so the patient's going to be able to use her blister packs on hand, along with some supplemental diuretic. And when it comes time for her next blister pack, the new dose will be incorporated. It's seamless for the patient. So that's the difference between 2015 and 2018. So things are moving forward. Thank you.
Thanks, Marty. And here's our contact information if anybody would like to get in contact with either of us about any of the projects going on at SASH and specifically this pilot. I grin ear to ear whenever we start talking about this pilot. There's been some great energy, some great work that has already started in just such a short time frame. And so, Margie, I'm going to turn it back over to you.
Thank you, Christy, and thank both of you, Christy and Marty, for such a great presentation. You know, there's really so many exciting projects happening. It's so great to hear about. At this time, we're going to open up for questions and discussion. Mayor, can you remind our attendees how to unmute the phone lines?
Yes, Margie. If you'd like to ask a question over the phone, just hit #6 to unmute yourself, or you can enter your questions into the chat box.
Great. Thanks, Nayara. And I know that while we're waiting for people to get into the queue, let's check and see if we have anything in chat. Do you have anything in chat, Nayara?
Yes, we have a question from Mary Lee Grosso for Marty, I believe. What metrics will you use to evaluate the impact of having community pharmacy as part of the SASH team?
At the moment, we're collecting the data, and actually that's we're moving towards using a tool to capture outcomes. Also, lab work will be one of the outcomes we look at. And we have some goals specifically of pulling patients out from high-risk meds to go to lower-risk meds. We'll look to see if we've been able to accomplish that as well.
And this is Christy. I just want to add, we're also going to look at customer satisfaction, if you will. How did things work for the members of the SASH team? And we're already getting very positive accolades from that, as well as our SASH staff and primary care providers.
Great, thank you. Any other questions in chat, Nayara?
Yes, Julie Reed is asking, how is SASH funded?
I can answer that. This is Christy. So SASH started out as the Medicare demonstration project, and we have now moved into, Vermont went to an all-payer model, I believe it was last year, and we have funding through, I believe the all-payer model ends, I want to say in 2022. So right now we are on a sustainable model, which is great.
Great, thank you, Kristen. Any questions from the phone lines there? If not, we have other questions in chat.
Yes, we have a question from Jessica. Is the self-assessment tool different from the Medicare risk assessment tool?
So the tool, that particular tool is more a tool for self-assessment for the patient. So I do believe it's a different tool. And again, it's something that could be found on the HHQI or Home Health Quality Improvement website under their fundamentals of reducing hospitalizations, their best practice interventions package. So it's more of a tool to be utilized with the patient. Do they understand their risk as opposed to the Medicare tool? Thank you.
Thanks, Eileen. Nayara, other questions?
We have a question from Marjorie, and we would just like to clarify who it's for. The question is there a tool that you can give to the patient to refer to when they are at home?
Hi, it's Melissa. I'm not sure I understand what Eileen just described as the self-assessment tool that we have the patients complete upon admission. But as far as if you're looking for any information that the agency can call upon, the home health agencies provide that in their admission packets, all the contact information.
Thanks, Melissa. Do we have other questions, Nayara?
Yes, we do. We just wanted to invite Marjorie, if that didn't necessarily answer her question, to just weigh in by pressing #6. But we do have another question from Catherine Murphy. For the Interact program, are you only using the Stop and Watch tool in the home care setting?
So for me, this is Eileen. So here at the agency that I'm at, right now that is the only tool that we're implementing. But I do believe that it has a full home health Interact package that you could look at. And I think as an agency, it's just looking at the tools that are available, looking at your own processes, what you have in place, and deciding what tools best augment your processes and what you're trying to accomplish for your, performance improvement or for decreasing hospitalization.
And just to tag on to what Eileen said, this is Melissa, the Interact does have other tools for home health, and we did pilot the Stop and Watch because we felt that was the most appropriate one out of all the package that would help in reducing hospitalizations.
Great, thanks. Nayara, has Marjorie weighed in at all on the phone? Do we know?
I didn't hear or see anything come in, but we do have another question. From Nina Arnold, is the self-assessment tool available in Spanish?
I believe, yes, if you go to the Home Health Quality Improvement or HHQI site, I believe it is available in multiple languages.
Great, thanks. More questions. I see we have more questions.
This is
Marjorie. Mayor.
Hi, Marjorie.
Hi, my question specifically was a medication list that is clear and simple and somehow lets people know the purpose of what they're taking, the name, the generic name, the dose, the time, all that. Do you have a tool like that that you give people to keep in their home?
Hi, this is Melissa. I'm not sure if somebody, Margie, if somebody would like to answer. However, I could direct you back to if you use your electronic medical record. A lot of agencies to comply with the new COPs are printing the medication list off of their electronic medical records, and some systems actually go and define it and actually print out what the purpose of the medication is and how to take it.
So I'll just jump in for a minute. This is Margie, and certainly there are different tools available that help patients, track their current medications and what the uses are, et cetera. Oftentimes when reconciliations are done, the pharmacist will leave a copy of those of the list of available or meds that the patient is supposed to be on, and discontinued meds, et cetera. Marty, I don't know if your pharmacy uses anything like that when you do med reconciliations for patients. And again, I can't answer totally for the home health agencies, but certainly those types of tools are available. So we can make those available to you on the New England website as well.
For our blister pack patients, it actually provides, the blister packs have a comprehensive list of all the meds with the times to be taken. It's actually also a tear-off card, so they can actually tear it off and take it to the doctor in the emergency room with them. If they're going to be admitted, it allows for better reconciliation. It does not show what the drugs are being used for. And from our computer system, we can also print off a nice layout of drugs, times that we can give to other providers. And that's something that we're doing. 5 years ago, doctors never asked for, no one ever asked for this information, and now we do it multiple times a day.
I know that patients that are eligible for medication therapy management as part of that process are typically given a list of the medications that they're on with, what they're using it for and dosing, et cetera. So it's a separate service. It's different than med reconciliation. So, but again, those tools are available within many of those packages, those software packages as well. Nayara, I'll go back to you. Hopefully, Marjorie, that answers your question or gave you a little direction. Nayara, I'll go back to you for other questions.
Yes, we have a question from Ann Rowe. What is the role of a home care agency in the SASH program?
Hi, it's Christy Tailman again. So to answer that question, the home health agency, what they do is we actually meet monthly with representatives from the home health agency, the area agency on aging. Occasionally mental health will join us at the table as well, and we will discuss clients or complex clients. The role of home health is to provide their expertise. One of the benefits of being a participant of SASH is you are gaining all of this expertise at the table to help solve your problems. So home health provides that expertise. They provide skilled nursing. The wellness nurses do not do any skilled nursing at all. Anytime there is a skilled need, that is a referral right into home health. And that's the SASH meeting that I'm talking about that occurs monthly. Those are a good opportunity for us to have those discussions of, is this a skilled need? Is this something that, we could work with home health on? And sometimes the home health nurses also say, hey, you know what, this is a perfect client for like telehealth or something along those lines. So that's how we engage. We have an assigned home health nurse to the monthly tables. Those are those panels of 70 to 100 people that we talk about. So the home health nurse really does get to know the people on the team, and we have good collaboration that way. Hopefully that answers the question.
Thank you, Christy. Nayara, we have more questions.
Yes, I believe this question is for the SASH team from Jessica Davio. And Jessica, please let us know if this is incorrect. Are you implementing this due to lack of VNA nearby, or how does the VNA come in?
We are not implementing due to lack of VNA. This is those needs with people that do not qualify for a skilled need at home. And it's really, like I said before, a program that promotes self-management, self-efficacy, a lot of patient education, so that folks are managing chronic illness at home with a support team in place, but not due to lack of home health, no.
Great, thank you, Christy. Continue on, Nayara.
This is from Julie Ward. For the pharmacy program, how do you work around the fact that many Medicare plans make it more cost-effective to get medications through mail-order pharmacy?
Well, as 80% or more of our patients do have Medicare, so they qualify for Medicare. The state of Vermont also has a plan patients can enroll in, and they pay a fee every month, but it also dramatically reduces their co-pays to rather reasonable amounts. So it really has not been an issue. It becomes an issue really more for the kind of the middle class commercial insurance retirees, but that's not really the patient we're seeing.
Thank you, Marty. Nayara?
This one is for the Connecticut team from Nina Arnold. Where does the Call Me First number go? What agency, providers? Is it 24/7?
So for us at our agency, we do promote, the patient gives the permission to put it up on their refrigerator. So it's visible, but it's, kind of patient choice. Where is it accessible to them? And then based on that, we go from there.
Thank you, Eileen. Nayara, I see we still have more questions, and we have time to go through them. So, next one.
We have a question from Tammy Rich. Similar to Marjorie, as a family caregiver, I help juggle and translate and teach my loved ones how to manage the med list, the follow-up appointments, transportation, any referrals. Do you provide a paper or electronic care plan for us to manage our care at home?
That's a great question, and no, we don't. I would actually direct you back to if you're the family caregiver and your loved one actually has home care in the home. I would direct you back to that home care agency.
Thank you, Melissa. I see we have comments and more questions. Go ahead, Nayara.
We have a question from Tanvir Khan. How frequently should we implement the self-assessment tool?
So as an agency, we were doing it at Start of Care. And so I think it's really based on your patient assessment and on their needs and the plan of care itself. You know, is it changing? Have they experienced a change of condition? Does it, change the picture for you where you need to revisit and see if they understand that risk? But it's something for us that we implement at Start of Care. So definitely at that juncture, and then I would individualize it based on what the patient's course of treatment looks like.
Thank you. That's great. Nayara?
From Nancy Green, how does the HHA and SASH work with the area agencies on aging?
I'm wondering what HHA means.
Home Health Agency.
Home Health Agency? How does the Home Health Agency and SASH work with agency? Okay, got it. Nancy, I'm going to go back to the comment I made about the monthly table meeting, the monthly meeting that we have, and that is where members from Home Health and SASH and Area Agency on Aging will come together to talk about their clients that are part of SASH. So it's that collective wisdom, if you will, that's shared at the monthly meetings.
Great, thank you. Nayara, do we have anybody on the phone lines?
If anybody does want to ask a question over the phone, just press #6 to unmute your line.
Okay, so we have more questions in chat while we wait to see if anybody wants to ask something from the phone.
Mary Lee Grosso is asking for Marty. Do you have a similar communication process with your local LTC facility if patients have a short stay in the SNF and are discharged home?
We are slowly getting there. That's kind of the last piece of this puzzle for us. It's better than it was, but we're probably only getting direct communication, 70 or 80% of the time. But that's up from 0% of the time 2 years ago.
That's great. That's impressive. Nayara, other questions?
Jessica Zivio is asking if SASH is state-funded, but I do believe that one was answered. So we have a question from Tammy Rich. The support of this program is terrific. Do you compare any measures over time of patient experience with your program to see if people feel more confident managing their health? Also, how do you identify patient-family pain points or issues that need improvement? Do you use any focus group or patient advisory councils to engage in dialogue about how to better serve unmet needs?
This is Christy. I'm believing this is focused at the SASH program, and thank you, Tammy. Interestingly enough, we just completed a qualitative evaluation with our wonderful partner, which is the Vermont Department of Health. So we did look at patient experience and how the impact of the SASH program was having on their perception of health. And it was a wonderful outcome, really gave us some good insights. And of course it also, enlightened us to a few areas that we can work on. And that is some information that we are using to identify, I would say, some of the pain points that we need to focus on for future. Do we use any focus groups? We do. It is sporadic and it is dependent on maybe some issues at hand that we're trying to understand. Patient advisory councils, there are typically some key participants at the housing sites that do help the staff develop some of the programming that we offer at the housing sites, and we get to understand a little bit more about what's going on with the family of our participants as we start to work with them as well. So it's not an exact science, but those mechanisms do they do occur. And I'd say the biggest one, though, has been the recent qualitative evaluation. It's given us just so much wonderful information that we're digging into.
Thanks again, Christy. I think we have time for a couple more questions. Mayara, do you want to continue?
Sure. We have a question from Lisa Freeman that was sent to all attendees. So we just want to remind everyone when you do send a question to send to all participants. But her question is there data that reflects how this has impacted hospital ED visits and or exacerbations of chronic conditions?
Is that focused, do you think it's SASH? Yes.
Yes.
Okay. So yes, we actually were, because we were a Medicare pilot project, we were evaluated by a third-party company, and that is called RTI, and they looked at cost savings per participant. And our reports, if anybody was interested in looking at them, are available on our website, which is www.sashvt.org. And so we have shown a decrease in expenditure. It's roughly around, I think, $1,200 per Medicare beneficiary per year is the cost savings. So you can take a look at that on our website and dig into that in much further detail, but we have looked at that by a third party.
That's great. Thanks, Christy. I think at this point we shall start to wrap up. I want to first thank all of the speakers. You did a great job. Thank you for the very rich discussion that followed. So, again, thank you so much for your participation. For those pharmacists who are claiming continuing education credit, the ACPE code is HOME, H-O-M-E. You'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. If you're interested in learning more about our programs, or if you want to collaborate with us on any of your initiatives, please feel free to reach out to the care transition leads in your state. They're listed on this slide for your convenience. And at this time, I'm going to turn it over to Mayara, and she will wrap it up. Thank you again so much.
Thank you, everyone, for joining. We just have a few final announcements before we end today's call. As you can see from this slide, we are now on social media. Please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, we'll receive an email tomorrow with a link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation was in your Day of Details email and is posted on the website, and we will add the link in chat as well. Within the next few business days, a recording and transcript of this webinar will be added to our event webpage. Thank you everyone for attending, and have a great rest of your day.